Good evening, everyone. Here Imran Abbas. Again, we are live. Please. Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live on GLR TV. We will continue our series of safe sleep gastrectomy that we have started since July 2021 with Professor Patrick Noel, who is a well-known bariatric surgeon and expert in sleeve gastrectomy. And luckily, today we are with Professor Zandi from Tehran, Iran. He's a big name in bariatric world, and he has started his bariatric surgery more than 2 decades. Personally, I have learned a lot from Professor Zandi, and also he has a great experience in sleep gastrectomy, and it is great honor for myself to interview such a great personality. Professor, so much thanks to accept our invitation. Over to you, sir.
Hi, dear Dr. Imran.
Yeah, please, sir. Please, sir, we will, because we have some questions. So as you know, these are repeated questions because at the end we will have some obsession. So we have some protocol. Personally, I know, but for our viewers, sir, first of all, please your brief introduction.
Thank you, Dr. Imran. Did you hear me good?
Yeah, we can hear you, sir.
Thank you very much about the invitation by you about the sleeve gastrectomy. And I'm Dr. Zandi. I'm a bariatric surgeon. I started in 1997 in Tehran, and I have a lot of courses in Elancourt in Paris, and also in Belgium, and also in with Professor Miller in Australia, and with Dr. Gaini, and a lot of bariatric surgeon in the past. And I have more than 20-year experience about the bariatric surgery. I started with open VBG and open gastric bypass. Then I advanced to go to gastric banding by laparoscopy, adjustable gastric banding with Mr. Royston in a Hull City in the UK. And also going advanced in a gastric bypass. I started gastric bypass in Tehran in 2003 and 2004, and around maybe more than 3,000 gastric bypass in the last 18 years I did it. And also more than 700 patients with gastric band, and more than 5,000 patients with gastric sleeve.
Sir, excellent, really. So it is definitely a great honor to interview such a person who did more than 5,000 sleeve gastrectomy and has experience of bariatric surgery more than 2 decades. So definitely today we will have a great session. And in my opinion, it is great opportunity for our youngsters to know more about safe sleeve gastrectomy. Still, sleeve gastrectomy is the most common bariatric surgery at the globe, but definitely we are facing some issues. Today, I will try our best. So ask some questions from Professor, and definite Professor convey his message how we do this sleeve gastrectomy. Then you will face less complication. Sir, when and why have you started sleeve gastrectomy?
To be honest, I started sleeve gastrectomy in 2008, 2007, because as you know, after 2005, after the do not switch, laparoscopic duodenal switch coming up, and the first step of the duodenal switch was sleeve gastrectomy. And after 2005, a lot of the surgeons starting sleeve gastrectomy, and I'm waiting and hear about these reports and also documents and also all literature about this. And I think maybe it will be good and much better than VBG, because as you know, the VBG is one type of restrictive operation for the bariatric surgery. And I that moment I changed to open VBG to sleeve gastrectomy. All patients that had the candidate for the gastric bypass or gastric band, I candidate for the sleeve gastrectomy. And as you know, the gastric sleeve going up and grown in 2011 to 2019 from 80% to 60%. And now most frequent bariatric surgery in all of the world is sleeve gastrectomy. But I would like to change this safe sleeve gastrectomy to safe and correct sleeve gastrectomy, because safety is not complete cover the sleeve gastrectomy. In the first of all, we have to thinking about it. Is sleeve is enough for the patient? Is gastrectomy is good for patient? And also in a long time period, as you know, we did operation for more and more younger than patient, maybe in teenager patient. What happened in a 10 year, 20 year, 30 years? What happened for this patient? Is it safe? Is it everything is good for this patient? For this reason, if we want thinking about the sleeve gastrectomy, we have to do this correct. It started priority to the operation, started by the good and the perfect endoscopy, upper GI endoscopy. Is this patient have gastroesophageal reflux, Barrett disease, or the problem with the stomach and the type of the stomach, and also about the diet of the patient? This patient has a good cooperative about the diet, about everything? Because as you know, the one of the most frequent complication in the long time is gastroesophageal reflux, and unfortunately the sleeve gastrectomy have linear related to the gastroesophageal reflux around 13% per year. For example, if your patient in a third year after the operation has 20% have gastroesophageal reflux, maybe after the 10 year, 15 year, it's going up more than 15%. But it is very fair, we fair about it, because there's a risk of the Barrett's esophagus, and also unfortunately adenocarcinoma of the esophagus. And the patient with sleeve gastrectomy, we don't have any organ for the reconstructed esophagus. If I found, for example, in an earlier stage, T1 or T2 esophageal cancer, that we have thinking about the cured esophagectomy, but we have do, for example, colon reposition and something like it, because we caught all of this arcade in the greater curvature, and we have a problem about this.
Sir, we will go ahead, and also we will talk about definite patient selection, and also we will explore these points. So now we are talking in 2021, and about 2 decades you are practicing sleep. I remember at that time in 2000 that so there was limited procedures, definite, also so not so much experience of such, but nowadays so definite. So now social media, we have access to YouTube, and also lot of training centers at this globe. So there are variety of bariatric surgeries. There is not only restrictive procedure. We have malabsorptive, hypoabsorptive, hybrids, many procedures. And as I know, you are one of them, that you are practicing for your patients, all types of procedures. What's my question? Now in 2021, which percentage of your patients belong to sleeve gastrectomy?
In my experience, between 35 to 50.
Excellent.
But
yeah,
but so sorry. But if I choose the operations, I think between 30 to 40 is enough, because I think not more than 40% of the patient is good candidate for the sleeve gastrectomy. But with this propaganda about sleeve gastrectomy and a lot of Instagram, for example, WhatsApp, everything, we're talking about the sleeve gastrectomy. A lot of patients have a candidate for the sleeve gastrectomy, and we don't accept the gastric bypass, to be honest. But I think between 30 to 40% of the patient is good candidate for sleeve gastrectomy with good follow-up, and everything have good for operation for these patients.
Sir, because now we have viewers from all over the world, and you are live on Facebook group Global Laparoscopy, and also this interview remain here, and also again on YouTube channel. Also, we have viewers who are youngsters and just now going to start or just started sleeve gastrectomy. So you ask good patients for sleeve gastrectomy. What is your definition? Who is good patient for sleeve gastrectomy?
In a definition, good patient for the sleeve gastrectomy is first of all was have the patient with not be sweet lover in the first. In upper GI endoscopy, we don't have any esophagitis, and also Barrett esophagitis, and also hiatal hernia. And this patient is good for choose for the good candidate for the sleeve gastrectomy.
Sir, if someone is youngster, so just imagine 20 years old, morbid, obese, but he's a sweet eater, sweet lover, what you will do?
How about BMI?
BMI 51.
51. I think gastric bypass is choice.
In 20 years old.
Laparoscopic, exactly. Gastric bypass, classic gastric bypass is choice of 51 BMI. The patient is, I think, choice.
Sorry, we change BMI, we decrease BMI 40. So BMI is 40. So they are...
In the lower BMI is 40, 38, 42. Maybe sleeve gastrectomy. If he doesn't have any esophagitis, might be remembered about esophagitis without any hiatal hernia. It's not contraindication for the sleeve exactly, but Barrett esophagus and or hiatal hernia, more than not small hiatal, medium hiatal hernia or large hiatal hernia is not good candidate for the sleeve gastrectomy.
Sir, because definite, as I know, so personal directly you have dealt more than 10,000 bariatric surgeries. And also if we see so different groups and also other colleagues, you have a vast experience of bariatric surgery, there is no doubt. So what is my question? So how many cases you have faced Barrett esophagus?
To be honest, I didn't do not yet any good follow-up for the patient with upper GI endoscopy, and I'll try in the next year, in the next if so the Congress have one paper about this, because I prepared for the 1,000 patients after the 2 to 10 years, after 2 to 10 years sleeve gastrectomy. I will do gastroesophageal endoscopy, and I can tell you at this time about the Barrett esophagus and also esophagitis and also everything like this.
So if we see, so no, before surgery. So just now you are, because routinely not, I
Before,
don't think, yeah, before surgery, how many cases you have?
before surgery, I didn't do any patient with large or medium-sized hiatal hernia sleeve gastrectomy, but with a small hiatal hernia or esophagitis grade A, not B or Barrett esophagus, they can be candidates for the sleeve gastrectomy. If the patient choose the sleeve gastrectomy, I did it, and also I think around 10 to 12 or 15% of the patient had this situation. I did sleeve gastrectomy, 10 to 12 or 15%.
Sir, my question regarding that Barrett, because that is very important, and because when we in different international conferences always highlighted this, and it will be cancer and definite. So my question, so you, because definite you did routinely, not routinely, so some cases before surgery you do so upper endoscopy. How many cases were before surgery
Before surgery,
were Barrett esophagus?
less than 0.5%.
0.05% were.
Yeah.
So, sir, big. So when you see 10,000, so what is your protocol of endoscopy, pre-op endoscopy? Are you do endoscopy for all of your patients or no? Selected patient, only symptomatic?
Selected patients. At the moment, is selected patient, but I'll try to do after the 3 years for all patients routinely between 1 to 3 years routinely.
So, sir, how much
do
your
it.
follow-up? If you see percentage, so now you are doing one after 1 year and after 3 year. So how much your percentage follow-up? 50% follow-up, 60, 70?
Around 50 to 60%. Unfortunately, between the 40 to 50%, I didn't have any follow-up because
It
even
means so
come back.
in 5,000 cases, so about 2,500 you did upper
100.
endoscopy. What was your common finding in these cases?
I think at the last 5 years, I did more than 25 patients change to sleeve gastrectomy to gastric bypass just about the esophagitis and the reflux disease. But maybe some of them don't refer to me and go to other colleagues.
No, sir, my question. So now you did just because this is a great data, and if we see it will be great help, because why we are discussing this? Our main target is safe sleeve gastrectomy. We must highlight our weak points. Then we can think about, so how can we solve these points? Then yes, we can convey our message to the world. Yes, these if we follow 1, 2, 3, 4, then definite you will face less complication. And I agree with you. Sleep, just imagine a 20 years morbid obese patient. So maybe he will live 80 years. So then just imagine, so he will be 60 year with a malabsorptive surgery. So then there are, as you know, no, just my question, sir. So if we see these things, so what is my point? So definite, we need to help our patient and help our type of surgeries. And in my opinion, so sleeve, in my opinion, is a good surgery. So, but unfortunately, due to some issues, so highlighted different points. So what is my question? So regarding this, because you did 2,000 plus upper endoscopy after a sleeve gastrectomy, what was the most common, because you did for all of your patients without any, so sometimes some of surgeons they do upper endoscopy only for symptomatic patient after surgery, but you are following your patients about 2,000 cases, you did upper endoscopy. What is my question? What was the most common finding of upper endoscopy? Maybe patient was no symptoms, no symptomatic, no issue. Oh, you see, this is what was the most common finding?
Dear Dr. Imran, I told you I did at the moment for the symptomatic patient.
Only symptomatic.
But I plan for in the next for the all patient between 1 to 3 years. Okay. I did upper GI endoscopy for the first of all for the making one good review of the patient and make one big good chapter about this. And in the next if I found more than 30% with the bad or maybe severe esophagitis, maybe I did as a routine for the after 1 to 3 years. If I can't, I don't found more than 30%, I changed the problem just like here, like now, for the just patient with symptomatic patients.
Sir, how much now? You did 5,000 sleeve gastrectomy. If we see, yes, I know because I know the culture of our areas, and also patient go one patient to other doctor to other doctor, change their doctors, and maybe so. But those patient who consult to you with symptoms, so can have you any data? So which percentage of your patients are symptomatic, any type of GERD after sleeve gastrectomy?
For sleeve gastrectomy, really between the 10 to 25% of the patient with sleeve gastrectomy after the 2 years come with some symptom of reflux esophagitis or some problem like this. And also around 30 to 40% of this patient after the 3 to 5 years come back with weight regain.
Sir, we will go. Yes, we will also talk now because we are talking. So yes, you take every surgeon when they start surgery, just lap chole, hernia, any type of surgery. So progressively with the passage of time, so we learn from ourselves, definite. And also bariatric is one of them. When we start our bariatric surgery, then we say, oh, this was the point, this was the point. I must do like this, I must do like this. Progressively, we evaluate our technique. So, sir, during this period, now about 13, 14 years, you have started a sleeve gastrectomy, and definitely you have changed your technique for your better results. Can you highlight those points that you have changed? And now in 2021, you can ask, yes, Professor Zandi technique for safe sleeve gastrectomy is this.
I started sleeve gastrectomy with overswing from the first time. In the last 15 years, just one patient, I didn't do this because it was very, very fatty and I can't do this, really.
Yeah.
But all of the other one, I overswing. And I think overswing is very good for the position of the stomach much be better after the operation. The risk of twisting is near to zero, and the rate of the hemorrhage complication is coming down. But unfortunately, I don't know it is effective about the leak or no, because I had 3 leak in the last 15 years, and all these patients I did overswing, but leak happened. And in the second line, we're starting before in between the 5 to 8 centimeters, but now change to 4 to 5 centimeters from the pyloric area. And no time go to down more than 4 centimeters, because if you're going to down near to pylorus area, the risk of the complication is going high in the first line, and also the rate of the vomiting and nausea in the patient is going up more, because the irritation of this pylorus area is the risk of the nausea and vomiting is going up. In the third line, I used, if possible, I used 45 millimeter black cartridge in the first one. Direction go to left upper, not direction going down, because they like a boot. We make a stomach like a boot, not like a banana. It's completely like different. It's the hockey stick is exactly like a hockey stick. The risk of the stenosis in a between first one and second cartridges is going down. And in the for the definition of the where we starting the first cartridges, we have the some adhesion in a posterior wall between the 5 to 6 or 4 centimeter near to pylorus. This adhesion is good sign that meaning is finished. Here is enough for going down. Don't go more than it. And in the middle, we have sometimes some adhesions between the pancreas and left gastric and gastric wall. We have to release complete these adhesions if we want have a good direction and good sleep. In the last, for the releasing of the fundus, we have completely released the fundus, not as any time the first time that is starting for releasing, but after the 3 of cartridge or 4 cartridges that we use, in the end, we completely release this area because we can see much better. We can turn the fundus, and the risk of the damage to splenic artery is coming down. The risk of the splenic damage is coming down. The risk of the bleeding is coming down. And one of these very, very important point about this sleeve gastrectomy, we have to save the arcade of gastroepiploic in the right side in the greater curvature. As you know, we have the complication thrombosis, portomesenteric thrombosis in a sleeve gastrectomy. I think, I'm not sure about it, but I think the risk of the closure of this arcade, the risk of this thrombosis is going up with for the avoiding this complication. We have completely close to the stomach and save this arcade, and don't close this arcade is very, very important for the overswing, and also for the closing the short gastric, and also this less greater curvature vessels. All after this one is very important for the safe sleeve gastrectomy. And one of the distant point, I saw a lot of the bariatrics don't use the long instrument, and with normal instrument, normal size between the 34 to 36 centimeter instrument, did sleeve gastric bypass. In this upper area, I think you have to, you must use the long instrument, because for access, good access, and without any pressure, any bad situation at this area, if you don't use the long instrument, you can't completely release these adhesions, and you can't do good operation, I think.
Sir, excellent. You have highlighted excellent points, and in my opinion, so it will be a great message for our youngsters. But I have some question. So during your debate, so one point that you have highlighted, so regarding the dissection of upper area. So as I understand, so you do gastrolysis completely, but the dissection of that left crust or till left crust, so you do after third or fourth stapler. Am I correct?
Exactly. Not any time, not all time. Sometime we have a lot of adhesion at this area between the gastrosplenic ligament. We have gastrosplenic ligament here, and very, very close together, and very badly adhesions at this area. If you want try with force and releasing, maybe you have damage to spleen, maybe you risk of the bleeding. For this reason, sometimes I'm going up until for example, maybe 2 or 3 of short gastric close. The last one, I save it and going down and starting with cartridges and coming up. And in the end, I bring up the stomach, and after the bring up the stomach, we can see very good. And I have the one right angle, big right angle for the releasing our adhesions, and with the ligature or other energy source device for releasing this area.
Sir, what is the size of your bougie or that size?
32 to 36, just.
So 32.
Not less than 32, not more than 60, 36.
And still you imbricate and you oversew this your staple line.
It is important. You can't use in the oversewing. If your needle going through and through, and if at the time of the closure of these sutures, maybe you have damage to stapler line, you have to implicate it very, very, very fine, very, very fine imbricated, because the risk of the hemorrhage and the hemostasis is much better, and risk of the bleeding is coming down. If you overswing through and through, at the time of closure, the risk of this stapler opening is much, much more.
So it means, so you using routinely maximum 36 bougie, and
exactly
stapler just kiss the bougie, not tied to bougie, then you can easily imbricate your stapler line.
In the 36, you cannot, you can be completely close to bougie, but as any time that I want firing the cartridges, we're testing with bougie coming inside and going back as any time. If bougie is closed and don't coming right very easily coming inside and going back, is meaning is very tight, and you have changed the cartridges place.
Sir, definite wo progressively when you see, so about GERD after a sleeve gastrectomy. So as you know better than me, the size of that gastric tube is very important. Patient selection, that MDT. So role is very, very, in my opinion, all types of bariatric surgery, the most important is patient selection. And definite, progressively we learn from our patients, from others, from different, so from literature, yes, we learn. So now in 2021, if you compare, so just 2-3 years ago, just since 1918, if you compare with 2008, if you compare with 2012, your sleeve gastrectomy, definitely your patient selection is now different than that time. So are you think, so now this GERD after sleeve is less than that time or no, same?
Pardon, what
this reflux after hysterectomy is same still or no? You think after patient selection, after this technique, after these points, so now your incisor is not so much tight, and also your this sleeve is not twisted, there is no functional or technical or mechanical obstruction, and you are little far from EG junction, everything standardized, patient selection was excellent. So you never do for a symptomatic patient. Are you think now GERD after a sleeve is less than before?
I think if a patient selection was be perfect, no different for the patient, I think. But it depends on the patient selection. As you know, good bougie size, good operation, no hiatal hernia, everything was good. I think patients, we don't have any more refractive esophagitis.
So why I'm asking, sir, this one? Because if we just, as you have earlier highlighted, if someone will suffer with the esophageal carcinoma after a sleeve, we have no option. Only we have colon interposition because there is no gastric tube. So due to this, so we must think about these things. So it means from your side, the most important point is patient selection. If you will, yes, technical points are also no doubt very important, but the most important, if you select exact that patient who is a good candidate for sleeve gastrectomy, then there will be less chance of GERD after a sleeve gastrectomy.
So sorry.
Yeah,
sorry. This is
Okay, sir. Sir, we will go ahead. We will go ahead, and
Yes.
also we will talk about according to your protocol. So, what is relative contraindication, not absolute, relative contraindication of sleep gastrectomy?
Relative contraindication of sleeve gastrectomy is medium-sized hiatal hernia, and also is Barrett's esophagus. No, sorry, Barrett's esophagus is absolute
Yeah, yeah.
contraindication. Esophagitis, GERD B, in meaning more than 5 millimeter, 5 millimeter esophagitis, and breaking the esophagus mucosa, and also uh, that to this is very important. And maybe history of the esophagus carcinoma is at least 2 generations of the family.
Okay. Sir, one question. So sometime because as you know, and also you have highlighted, unfortunately, this social media also misguide the patients, especially this Google and also YouTube channel different. And patients also think they know everything. So they insist, I like only sleeve gastrectomy. I will never go for bypass. Maybe in their family they face some issues and like this. But patient is symptomatic. You did endoscopy and that was grade B, or that was some esophagitis, not Barrett, nothing. That was not absolute contraindication, and you did sleeve gastrectomy, but condition become worse. Have you faced such a situation?
Fortunately, I don't have at this some situation like this. But if the patient don't have absolute contraindication, I did it. I do it, but
Okay,
I did in the past sometime. But I told the patient they have to good follow up and also endoscopy, and if they have any problem, any symptoms, we have to go to endoscopy, and we have the problem again, and maybe problem getting worse, we change to gastric bypass or anything that they have need.
excellent. Yeah, already you take consent from the patient. Sir, another thing that you also highlighted, and it was really impressive. So this after this 5,000 cases, only 3 leak. But again, still leak after sleeve gastrectomy is a nightmare, also for the patient and also for surgeon. So, what is my question? So, when was your last leak? How many years ago? You
3 years ago.
3 years ago also you have faced this.
Yes,
And at that time, definitely,
exactly exactly 3 years ago.
it
1 year before the pandemic.
yeah pandemic. It mean so
Yeah.
at that time your this technique was standard. Your patient selection was excellent. Nowadays, yes, we are because we are dependent on technology. You have best stapler. Everything was fine. What do you think in that case happened,
Now,
Lee?
in the last one, I know. In the last one, I used the harmonic,
Uh,
and I did harmonic. I think the blade of the harmonic that was hot,
yeah,
maybe have a damage to this area. I did the operation on Thursday, and I sent the patient in a Saturday, 48 hours after the operation, and he came back to hospital in the morning of the Tuesday at 2 a.m.
5 days. Yeah.
and yeah, and 5 days, and I did it in the morning at 7 a.m. I did esophagogram with the dye, and also I saw the one small leak, and at the moment very fast I go to operation room, and I did laparoscopy, and I find a very small area, completely dye coming out, and I breaking in the lateral, and I use one cartridges, purple cartridges, and close this without any problem.
No, no, this is interesting, sir. So it means This leak was from,
It was technical. It was technical.
no, from which area? From which area?
Just behind the stapler line, two
No, no,
millimeters
behind the stapler near
upper,
EG junction.
in upper, near
So
junction,
have you
exactly.
space for your stapler? Because routinely you
Exactly.
irritate.
No. I around 2 to 3 millimeters this far from the stapler line toward the medial of the stomach.
So, sir, you can present this case because there is a lot of inflammation and also stapling
No, I did.
area.
No, it doesn't have any inflammation because they started as 2 a.m. and I did operation at 9 a.m. after 6 hours.
Oh my
Without any inflammation, without anything, very teeny watery discharge here, without any fibrin and any infection and anything.
Because why I am asking this? Because after 4 5 days, this leak, the most common cause is ischemia. If there is technical, so technical within 24 or maximum 48 hours.
I think because I reviewed the film of the operation, and I think it was happened by the hot blade of the harmonic and this area. The first of the patient, the first my patient, it was in 2010, maybe 3 to 4 years after the starting sleep, maybe around 500, 600 patient I did sleep, and I had the first sleep leak in a day of 4, and I go inside and saw a lot of the a lot of the pus and a lot of the adhesions, and I did laparoscopy and washing everywhere and irrigating, and then put a drain, and after I put one sleep bariatric stent, long bariatric stent for this patient, and fortunately, at the moment stopping all of the leak, after the 3 weeks, I removed this stent, and patient has very good condition. Just 5 days in operation. After operation, second operation was in hospital.
Sir, excellent, sir, excellent. And because we are also live on Facebook group Global Laparoscopy, and Dr. Amir Hussain Mehdavian, pay regards. So definitely you know him. Sir, regarding that this portal vein thrombosis, you have highlighted and you have mentioned. So this is also really a disaster in my opinion, not only nightmare. So have you faced in your cases, in 5,000 cases, have you faced such a situation?
Sorry?
Portal vein thrombosis.
No, I didn't have. Fortunately, I didn't have.
One of the issue.
Yes, I fear some of my colleagues had these complications.
Sir, one of the factor for so that they highlighted for portal vein thrombosis is dehydration after a sleeve gastrectomy, because the sleeve gastrectomy is a restrictive procedure and patient is suffering with nausea, vomiting, and routinely we discharge after 24 hours. So are you prefer to, for these cases, to hydrate with IV therapy and also some patient, not all of them?
No. Okay. No. I don't routine prescribe any IV therapy, but sometimes, maybe less than 10% of the patient, as you know, in our country, a lot of patients go to some doctor in an area and they prescribe some IV therapy with saline or ringer lactate or something like this. But I don't prescribe any IV therapy for all of the patients. Just I advise to drink more and more water, juice, and everything watery, more than 2 to 3 liters per day.
Yeah, sir, what is your protocol of PPI after proton pump inhibitors after a sleeve gastrectomy?
Yeah, exactly. Between the 4 to 6 months after the gastric sleeve, and between the 3 to 4 months after gastric bypass.
Excellent. Sir, another question that is also, in my opinion, very important. And nowadays, because as you know better than me, this GERD or reflux after a sleeve gastrectomy is a challenge. And in different international conferences, always they highlight this point. Always they highlight, and also they ask, due to sleep, we face this issue, this will be cancer, this will, but again, still sleep is the most common bariatric surgery at the globe. So what is your message? I want to hear from your side for youngsters what they must do, so then there will be less chance of get after sleeve gastrectomy.
Dear Dr. Imran, I have confessed about this matter. One of what is the matter of this sleeve gastrostomy going high, grown high more and more is like the gastric band in the first time that's coming. A lot of surgeon, as you know, gastric sleeve much easier than, but not correct sleeve. Normal sleeve that a lot of the surgeons do is much easier than is gastric bypass and duodenal switch and everything. And also, in the other hand, the gastric sleeve is physiologic, as you know, one of the physiologic method, and also just restriction. If the patient don't have any problem, maybe very good chance for the control of the weight and control of the diabetes and control of the high blood pressure and everything. I am agree with you about it, but the problem is this patient is in the time of the first time of the endoscopy, we have to completely checking about the reflux of bile reflux inside the stomach. It is very important because the acid in a after sleep is not more, because a lot of around 80% of the 85% of the stomach will removed and acid is very less. But in the patient that don't have good pylorus and don't have competent pylorus, that sometimes go back bile from the duodenum to coming to stomach, the risk of the esophagitis and the problem with acid and bile together is much more than this. For example, in the last 3 years, we routine checking the bile reflux at the time of endoscopy. The patient with more bile reflux, I try to this patient go to laparoscopic gastric bypass, not to sleeve gastrectomy. Is much better. We have to completely thinking about it.
Sir, yes, I understand. But now my question, so which percentage of your patients were suffering with bile reflux before surgery? Have you any data?
Before surgery, they don't know it. They think just sometimes about the just gastric problem and upper GI problem, and sometimes with reflux symptoms. They don't know about how about it is this due to acid reflux or bile reflux.
No, sir, I agree with you.
We as a doctor, after the upper GI endoscopy, I found this patient have the bile reflux. For this reason
So my question is this: so, what was your clinical findings? It means endoscopic findings, not patient complaint. So now, just imagine you did 100 cases upper endoscopy, because as you have mentioned earlier, you prefer upper endoscopy only in symptomatic patients before surgery.
After surgery. No, before surgery, I did for all patients.
All patients.
After surgery, yeah, exactly.
So my question, which person? Now you did more than 5,000 sleeve gastrectomy and definite more than 10,000 bariatric surgeries. So what is my question? So how many cases were suffering with bile reflux in this 10,000 cases? Or you remember?
Really, I don't have. No, I don't. Because as you know, it need a good program for the checking after this. I don't have big, but all of the patients that's coming with bile reflux or acid reflux in an endoscopy, I try to change to gastric bypass, and I didn't do sleeve gastrectomy.
So it means
But as
patient
you
selection.
know, a lot of patients like sleeve gastrectomy, and they completely disagree with gastric bypass and told, no, I just want to do sleeve gastrectomy. If I don't have any absolute contraindication, I did it. Just I advise to them, you have to control endoscopy every 2 to 3 years.
So then, sir, in these cases, in that specific cases, so definitely you remember those cases, is situation become worse after surgery?
Which one?
That patient was suffering with GERD, suffering with was symptomatic, and they insist, and you did.
Yeah, I had at least 5 to 10 patients that I completely remember before the operation. They had esophagitis, GERD B, and they very told me that they want to do gastric sleeve after 1 to 2 years. That's coming and come back to my office and change. They want change to gastric bypass.
And all of them, you have changed, definite the
Not
situation, only one case.
all, at least 5 to 10 patients that completely remember before they had the gas esophagitis, but they don't have any Barrett, and they don't have any big hiatal hernia, but they completely agree with the sleeve gastrectomy. I did it after 1, 2, 3 years that they come to office for changing the situation to gastric bypass, because they have a lot of problem, a lot of reflux esophagitis, and also pain. As you know, some of the patients that's coming with upper GI endoscopy, very worse esophagitis without any pain, without any problem.
Yeah,
Some
asymptomatic.
patients come asymptomatic esophagitis, but some patients very small esophagitis, very great GERD A, and less than 5 millimeter esophagitis, that coming with much more pain and discomfort and everything worse at this for this patient.
Sir, excellent. So as you have explained and mentioned, so patient selection is most important, and it's great, in my
Exactly.
opinion, message for our youngsters. When you're going to start a sleeve gastrectomy or doing sleeve gastrectomy, please be careful. Patient selection, very important. If you do this, if you're going to do a sleeve gastrectomy for correct patient and also follow standard technique, then definitely you will face less complications. Sir, another question regarding weight regain. Just, yes, we are surgeons, also we are scientists, we follow our patients, and one of the issue is weight regain after sleeve gastrectomy. So now during these 2 decades, so now you have started sleeve gastrectomy about 2007-8, as you have mentioned, and now 13-14 years you are practicing sleeve gastrectomy, and more than 5,000 cases you did sleeve gastrectomy. Which percentage of your patients have weight regain?
Between 30 to 40.
30 to 40% after this, all this standard technique talk.
Yeah.
What is the main issue, you think? So patient don't follow that?
We have three problem about this patient. The first of all, in the maybe in the first group, maybe in the 500 first patient, maybe our sleeve not complete the sleeve.
Okay.
Sleeve bigger, and may sometimes fundus remain at this area. I remember, and I changed this completely technique. But a lot of patients coming with weight regain, sleeve size is good, everything is good, just they change to something that they eat. They eat a lot of sugar, a lot of something like Coke, and a lot of alcohol beverage, and also everything they very sweety eating. And for example, no one can eat, for example, half of pizza, just 1 or 3 slices of the pizza. As everybody know, with 1 slice or 2 slices of pizza, nobody can go weight going up. But every day, more than 100 gram, for example, chocolate and everything like this, and biscuit, chocolate, something like this. And all the patients in the last 10 years, around the 10 patients with sleeve gastrectomy with weight regain, I did re-sleeve around between 9 or 10 patients. But more than 80 or 90% coming, and I did gastric bypass. But this gastric bypass is some different with normal gastric bypass. In a normal gastric bypass, I use as a routine between 80 to 90 elementary biliopancreatic lymph and 100 to 120 elementary lymph. But at this patient that with history of any operation before, any bariatric operation before, I did at least 100 centimeter biliopancreatic, or maybe 120 and 80 centimeter elementary lymph.
Definite, sir. After any weight regain, after any restrictive procedure, we must go aggressive and need a dominant male absorptive component. There is no doubt.
Exactly.
Sir, it was really great discussion and really appreciable. You have shared your experience because also we are going to end now. This is the 1 hour completing. Sir, a political question regarding endoscopic gastroplasty. I don't know, have you any experience and what's your opinion about this?
After the sleeve gastrectomy, meaning after the
initial, overall,
initial,
yeah,
forget it.
Because why I am asking, because
sometime after gastric bypass, after sleeve gastrectomy, for example, for resizing the pouch or resizing the sleeve gastric, maybe with Apollo you can did something not exactly smaller than this situation, but in a normal stomach you don't do anything by endoscopy. As you know, we're releasing all of the greater curvature. We can't do very good small sleeve. How they can inside? Maybe you heard about the plication before.
I am doing
plication.
Still I am doing. Still I am doing, and I did hundreds of cases plication, and also then I faced weight regain. But now what I am doing, it's amazing. I add malabsorptive component, and now I am doing stapleless SASI. So gastric plication with ileal bypass, amazing result. We will discuss about this.
Forget.
I have discussed with Taleb.
Mr. Imran Abbas, forget about it, because I am not agree with any operation that we did loop gastrojejunostomy or gastroileostomy, because the backwash bile inside the stomach, the risk of the cancer, the risk of the ulcer, and the risk of the everything going up, and I am not agree. I disagree with all of this type, because all of this type is completely in against of the physiology, is against of the basic science. In a basic science, we learn the bile if coming up inside the stomach or esophagus maybe have dangerous. We can't do it by our hand. It's iatrogenic problem.
Sir, what is your opinion about mini gastric bypass?
Forget it.
Okay, then we will discuss. Definitely, then we will. Then this is a new chapter, because we will continue our series of because now this series will finish in December. This sleeve gastrectomy, and from January 2022 we will start a series Roux-en-Y gastric bypass till June, and from July 2022, we will go ahead with surgeries for low BMI like sleeve plus. So then hopefully I will also invite you, and we can discuss about like SASI, SADI, and other surgeries. And
no, SADI is different. SASI sausage is different with SADI. I am agree. I agree with this SADI. Maybe one of the good operation they can do as a Dudlon switch, laparoscopic Dudlon switch. Maybe SADI is a very good operation. But SADI is have some small and technique, and we have completely very fine technique about this. The SADI is completely good.
Sir, we will discuss definite in future. So this platform is for discussion. So this interview program is little different than webinars. In webinar, expert like you have no time, just 5 to 10 minutes, but here you have time, you can discuss, very friendly discussion in light mood. Sir, because now we are going to finish our session, what is your message for our youngsters who are just now going to start sleep gastrectomy?
First of all, thank you, Mr. Imran, about this good discussion, and also for the young surgeon. Any surgeon that wants starting as a bariatric surgeon, at least they have to do at least 2 operations: gastric bypass, classic gastric bypass, and sleeve gastrectomy. I think learning care about this operation is between 50 to 100 patients. If you do this learning care very good, I hope so you don't have any complications. For example, in the last 22 years that I did gastric bypass, I had just one time leakage, and we don't have any complication, not yet, because I starting very small by small and go to see hand of a lot of experienced surgeons and doctors, and it's very good for me. And I hope so everyone learning good and learning curve very good and don't have any complications.
Sir, so much thanks for your time, and really it was a great session, and you have shared your practical points and also shared your experience that was about 20 years, more than 20 years, your experience of bariatric surgery. Viewer, so much thanks. We need your support, and if you have any question, you can ask question in comments. Professor will be available. If you can send also question personally. We will continue this series of sleeve gastrectomy, and next week, Tuesday, 10 p.m. Dubai time, we will be with Professor Matthew from USA. He's a big name of bariatric surgery, and he was also here in Cleveland Clinic, and also now I think he shifted to USA, and we will be live with Professor Matthew next week. If you have any question regarding safe sleeve gastrectomy, you can ask in comments, and we are ready to hear from your side, and with your support, we can continue such academic activities. Sir, again, so much thanks for your time, and hope see you soon in any international conference.
Thank you.
Thank you, sir. Have a nice time.
Thank you. Thank you.